Good morning, judges and all. I will be presenting my case report on sphenoidal fungal sinusitis and vision loss. Fungal infection of the paranasal sinus was first reported by Jarnico in the 18th centuries. Sphenoidal fungal sinusitis is rare in immunocompetent patients. Infections involving the sinus is associated with dangerous complications because of the location and nearby important structures. It is commonly seen in female elderly patients with diabetes, hematologic malignancies, prolonged use of steroids, etc. Here we report a 38-year male patient who presented to us on June 2020 with severe complaints of left-sided painful gradual loss of vision with chronic headache not relieved by conventional analgesic since 1 month. There was a history of IV solumedrol which was given elsewhere 1 month back, following which patient became perception of light negative. There was no significant past and systemic illness. On examination, right eye best corrected visual acuity was 6, 6 and 6 with normal anterior and posterior segment findings, but in the left eye, perception of light was negative, RBD was positive, there was a limitation in the abduction movement, and on fundus examination, there was chronic disc edema. An urgent MRI brain was advised, which reveals ISO to high signal intensity in T1, W1, low signal intensity in T2 image in left sphenoid sinus with expansion and bony destruction of sinus walls encasing the apex of left orbit and compressing the left optic nerve, features suggestive of fungal sinusitis of sphenoid sinus with mucocele formation. Left-sided optic neuropathy due to fungal sinusitis of sphenoid sinus was diagnosed provisionally, and patient was referred immediately to ENT and neurosurgeon for needful. Patient was lost in follow-up for a few weeks. During this time period, he became COVID positive and he was admitted on a local hospital from 15/7/2020 to 29/7/2020. After discharging from COVID ward, he had undergone endoscopy skull-base surgery on 30 July 2020, followed by histopathological examination confirming aspergillus fungus, and he was given IV voriconazole 400 mg BD on day 1 and then 200 mg IV BD for next 10 days, and patient was advised to come after 10 days with the ENT surgeon. But patient came back to me with diminution of vision of the right eye after 5 months. Then he was again referred back to ENT and neurosurgeon as well as to higher center for needful. From this case report, what we can understand is that sphenoid fungal sinusitis are associated with dangerous complications like loss of vision, ophthalmoplegia, etc. And it manifests commonly with chronic headache and retroorbital pain. The frequency of visual disturbance is 24 to 50% of sphenoid fungal ball cases in previous studies. To conclude, early neuroimaging, early diagnosis, and timely surgical interventions is crucial for the improvement of vision and patient survival, because sphenoid sinusitis is an uncommon but it's a treatable cause of optic neuritis, and intracranial extension was the only statistically significant factor for poor survival. These are the references. Thank you.
Thank you, Dr. Iyer, for a very interesting presentation. Only thing I wanted to know, it was a sphenoidal sinusitis, fungal you are saying.
Yes, yes,
what fungi was isolated? Did she have any COVID background or immunocompromise? This was a lady.
No immunocompromise. He was COVID positive after the diagnosis of the sphenoid fungal sinusitis.
It's strange, very strange.
That's
Yeah.
And other thing is, initially it presented on one side, and you were saying the sixth nerve was also affected. Was it on the same side or the opposite side, the sixth nerve?
He was PL negative when patient came to me. Then he became right eye vision became counting finger 3 meter after 5 months of the endoscopic sinus surgery.
No, the sixth nerve which you were saying was affected on the same side of
left side, yes sir, same side.
Same side. So
yes.
How these two were related? What do you think was the relationship between sphenoid sinusitis and sixth nerve?
It was fungal sinusitis. It was compressing the optic nerve and the apex of the orbit.
And sixth nerve, how was it affecting the sixth nerve?
If it was affecting the apex of the orbit, then another nerve, cranial nerve should have been affected. No?
It was not affected. Only the abduction was only limited.
That is what you should have put your mind to that, because optic nerve is having a different anatomical location as compared to the sixth nerve. So probably the lesion was also extending to the cavernous sinus, and sixth nerve is supposed to be a free floating nerve in the cavernous sinus as compared to the third and fourth, which were fixed to the lateral side of the cavernous sinus. So maybe it was an early affliction in the cavernous sinus lesion, and this was a fungal etiology. It did respond to treatment, is it? She got better ultimately? We don't know.
He did not come to me, sir.
So you don't know ultimately what happened.
I called up the patient, and then he is alive, but he's saying that left eye vision already gone, right eye some amount of vision is left.
Okay, thank you for a very interesting presentation, and thank you so much.